Well, again, it's a pleasure being here today. It's nice seeing some familiar faces and talking to you about my favorite topic. Before I start, I will say that the PDSA group in the United States, there are three of the medical advisors here, Terry, myself, and Michelle Lambert, who's sitting right here. We're going to refer all pediatric questions to Michelle, okay? If they come up. But I also would say that patient organizations like this in ITP have been very helpful in the United States because they've encouraged the governments and the funding agencies to change their approach to ITP. And that's been very important, I think, in many patients to have new therapies made it more available than they might have not otherwise been in the United States. So I think right now it's important that you guys be politically active and also work with whatever insurance agencies you got to deal with to get reimbursements for what is obviously sometimes expensive care. But on that, I'll also bring you Caroline Cruz's welcome from the PDSA in the United States. So my first patient happened 41 years ago yesterday, was when I started my clinical training. It was a patient ITP whose platelet count was 1,000. It was a really neat, nice lady. She was about 25. I gave her some prednisone as my first patient as an intern in the hospital. Within 24 hours, her platelet count rose, and we were all happy. We sent her home. Then I saw her a month later, still on prednisone, 60 milligrams a day. Her platelet count was still nice and normal, but she was now diabetic, Cushingoid, gained weight, and was mad at me. So, and I suspect my last patient will have ITP and hopefully not be that mad. I'm going to talk to you about a number of topics today, and basically I work with a lot of different groups that develop new therapies for ITP, and my goal in talking about therapies in ITP and what's new is to probably give you things that as if I was talking to my mother at a level that I think many of you can understand and relate to. Also, if there are questions, please interrupt me. I think it's important to make this more interactive than just me lecturing to patients. But as Rob said, ITP is a disease of platelet destruction. Here's a cell called a macrophage, which is chewing up platelets. Here's a platelet which has been et, and here's one here about to be eaten. And this is the classic picture what ITP looks like in patients with this disease. You're destroying platelets. And we can make a cartoon version of this by saying here's the macrophage here, and here are some platelets out here. And what happens is antibodies come along. The antibodies up here, this orange structure, it binds to platelets, and then they get surrounded by antibodies. They then join what's called a receptor here in this cell called a macrophage. They bind to that, and then this receptor eats it up, and the platelet gets destroyed, as I showed you in that cartoon version a minute ago. So this is what's happening in patients' bodies with ITP in terms of destroying platelets. And this is how you should think about what's going on inside of you. But what's happened in the last 30 years is a recognition this same antibody, which is destroying your platelets in your spleens and elsewhere, also can attack the cell Dr. Bird talked about called a megakaryocyte. This is a large cell. This is the picture we're trying to show, Rob. But this is a large cell in the bone marrow. And what happens, that antibody, other things, the antibody binds to that cell called a macrophage, a cell called a megakaryocyte. Other things called lymphocytes can bind as well. This causes the cell here called a megakaryocyte to go under a thing called apoptosis or death. And what's happening in patient ITP is this antibody is destroying platelets in the periphery and also destroying your production of platelets in your bone marrow, giving you a problem. This is a lovely picture of Dr. Bird. He's a thin guy. He's making platelets in his bone marrow, and they're entering his circulation. And after 7 days, and this is data from here in Melbourne, after 7 to 10 days, platelets just sort of die, and they go to other places to be, the platelet graveyard. So you're making platelets at a small rate and destroying them. Then what happens in ITP is you have an antibody coming along. It binds these platelets, and they're cleared primarily by your spleen, but also by other organs in your body. And the net result is your platelet count tends to drop. This is the first day of someone's ITP. For many years, it was thought that we compensated for this destruction by making more platelets. This comes from data from Dr. Gernshimer's institution in 1968. And what happens here is we thought for a while that the body started to make more platelets, as this box A is shown here. That's not what's happening in patients with ITP. What's happening in ITP is you're destroying platelets at a rapid rate, but you're also not making them at a very rapid rate. And this is the underlying pathophysiology of ITP. So the current therapies are to either decrease the rate of destruction or boost the rate of production. And the therapies you all have been on are steroids, which drop this a fair amount. And the TPO agents and other things make the platelet production rate rise. And that's how you compensate for ITP with these different forms of therapy. So the standard therapies for ITP, this list gets bigger every year, and I apologize for it, but in general, when you treat ITP, in the black are things that decrease the rate of platelet destruction. You've all heard about corticosteroids and azathioprine, and I got to put mycophenolate up here sometime. Actually, I did right down here. You can whack out the spleen, which is what we have been doing for over 100 years, or you can block the receptors on these cells called macrophages that are destroying platelets, and that's with the IVIG and anti-D, danazol, and other medications. A new drug I'll talk about called fostamatinib eliminate the chewing up ability of your body to destroy platelets. And finally, there are things that increase platelet production. Thrombopoietin is one, and by the way, corticosteroids, as one of its mechanisms, also increases your rate of platelet production. So these are the things that we commonly use in ITP. And what I want to do is, not so much spend too much on these therapies, but I want to talk to you about what's new in ITP. And again, if there are questions or disagreements or, I don't know what you're talking about, interrupt me so I can clarify. So there are two new aspects of ITP I'll try to go over. One is going to be easy and one is a little bit more complicated. The first is to say there are new guidelines for treating ITP, and these will be published anywhere from November to January, and they're by different groups that have had great interest in the treatment of ITP. There are myriad guidelines, and I think right now every country and every region ought to have their own guidelines for how to treat ITP. That allows you to be a politically active group to say, hey, the guidelines say this, but we're doing that. Can we rationalize these forms of therapy? But there are new guidelines coming. I can't tell you what the final reports are going to say, but I can tell you what they'll contain at the very least. So the American Society of Hematology has already presented what they think the guidelines will be for comment upon. I'm going to just run through the list. Let me know what you think about these. So the first one is that the ASH guidelines say involve patients in making decisions. Has that been part of your ITP care? Have you been told what to do or been asked what would you like to do? Yeah, no, but this is a problem with doctors in general, and ITP in particular. So the major thing that ASH is going to say is, get patients involved. I can't do this very well. The second is don't admit patients to the hospital unless the platelet counts are less than 20,000 as a new diagnosis. So if you're a fresh ITP patient, we'll recommend admission for 20,000, but if you're over 20,000, you can be observed. And obviously, if you're a chronic patient, keep dropping your platelet count. Many of us wouldn't admit anybody to the hospital, any platelet count, unless there's actual bleeding. So these are the recommendations for numbers. Therapy is primarily for those whose platelet counts are under 30,000 or those who bleed. That's the other outpoint. Again, this is sort of common sense, which I think you'll all agree with, but now it's been codified in this document. The initial therapy, and hear this closely and don't hiss, okay? So, or boo, whatever the Australian equivalent of this is. But basically, so the initial therapy is corticosteroids. Dexamethasone or prednisone are regarded as being equal therapies in this disease complex. But here's the important point, but not for more than 6 weeks. So this is the major change for all of the guidelines which have come out. So truncate, as Rob says, the exposure to corticosteroids at significant levels for under 6 weeks. And again, I've had patients come to me who've been on 60 milligrams a day for 5 years. They look like the Michelin tire boy. They have horrible disease from the steroids. So this, I think, is probably the key thing. The other thing is to defer splenectomy for at least 6 months, for at least 3 months. One of the other guidelines will say defer it for at least 1 or 2 years. And the reason why is that most patients, a third of all patients, will have a spontaneous remission in the first year. And if you wait 5 years, 80% of patients will have remission in 5 years. So there's a lot of data that says if you can hold on long enough and not have any bleeding risks, that the longer you delay, the less there is a need for splenectomy in patients with ITP. But this will be codified to be at least 3 months, and in one of the guidelines will be at least 18 months. If you don't respond to steroids and still have a low platelet count, and hear this in the way that I'm going to tell it, we do binary analyses. Is therapy A better than therapy B? So if you fail steroids and your counts are still in the range where you need to be treated, the question is, what's the option? Rituxan, TPO receptor agonist, or have your spleen taken out? And the current ASH guidelines will say that if you're corticosteroids, the TPO receptor agonists are better than rituximab and are recommended in that situation. Okay, so that's comparison one. The second comparison is, well, if you're not going to use a TPO agent, rituximab is favored over splectomy. And so the guidelines will say if you're going to take someone's spleen out, give them, of course, rituximab first to justify the need for splenectomy. And then the third thing comes down to if you make the third comparison. So the three drugs being compared are TPO receptor agonists, rituximab, and splenectomy. And these are all binary comparisons. And the problem we face with decision-making medicine is we don't always use binary comparisons. We oftentimes have myriad things we're comparing, but this is how this is done. So the first result is that TPO agents are better than Rituxan. Rituxan's better than splenectomy. And then we say, what about TPO versus splenectomy? And the guidelines committee here equivocated. And I won't go into the politics of this, but it was politics. And it basically said that TPO receptor is equivalent to splenectomy, but let the patient choose. So which of you is going to choose splenectomy over a medication? Anyone? So the people who do this are Air Force pilots. I take care of Air Force pilots, ITP. They want to get back in the air. These guys are crazy. They want to get back on that aircraft carrier, and they want to land it tomorrow, and so we'll take their spleen out. But that's the only group of patients I've taken a spleen out. I'm a flight surgeon for the Air Force. So this is the list of things that you'll hear in terms of guidelines, and this is what's going to come out, I think, from the American Society of Hematology. There's another group called the International Consensus Groups that will come out. The German guidelines already said this. The Israeli guidelines already said this. The Japanese guidelines said this. So, there's a lot of similarity, and this is what's going to appear in the next 6 months in terms of things you can use to help your doctor make decisions. For those, anyone do pediatrics here, or anyone have kids with ITP? No, I know you do. Okay, so just for a brief, there are also guidelines for pediatric patients, and let me just briefly go through those for 1 minute. Involve the patients and the parents in the decision making. Number one. Number two, children with no or minor bleeding should not be admitted to the hospital at all. Number three, if you only have minor bleeding, the initial therapy is do nothing, observation. Not corticosteroids, IVIG, or anti-D. And Michelle, you can add your 10 cents worth if you think these are wrong. If there's non-threatening mucosal bleeding, meaning you think the patient needs to be treated, corticosteroids at low doses for 7 days are the preferred therapy. Prednisone, not dexamethasone, not longer than 7 days. And if things are really bad, IVIG is the same as anti-D, but in general, corticosteroids for 7 days is the major therapy recommended. There are kids, and I don't deal with them at all, who fail corticosteroids and fail IVIG and still have a low platelet count. If you're unresponsive to these agents, the TPO receptor agonists, not rituximab and not splenectomy, are preferred therapies for kids. So right now, as I think ought to be true for adults, the preferred therapy in kids is going to be if you fail the corticosteroid route or IVIG, that the TPO receptor agonists are the recommended form of therapy. So this is what it will appear in both sets of major guidelines coming from one from ASH, the American Society of Hematology, one from an international consensus group, which does include Australia's influence. So that's what's new in terms of recommendations for patients and doctors how to treat gout. I want to spend a little time on new therapies for ITP and tell you how they might work. So there's a whole list of things here I'm not going to go through. There are a whole bunch of things being done to block the macrophage chewing, okay? There are a whole bunch of things we can use to make the antibody disappear. One is a thing called anti-CD40 ligands, forget about the name. I'm going to focus on a thing called a neonatal FC inhibitor. This is a technique I'll describe in a second to make the antibody attacking your platelets disappear. There are other things that can be used to block the spleen. Those things called macrophages, which are chewing up, and the lists are shown here. I'm not going to go over the names at all, but there's one that was just approved in the United States called fostamatinib that can turn off your macrophages from chewing. I'll describe that in a bit of detail in a second. There's a research drug called Bruton kinase inhibitors, which I don't think I'm going to have time to talk about much, but they also turn off the macrophages, these things that are chewing up your platelets. I'll mention briefly, if it's okay, Terry, unless you're going to cover it, the use of recombinant TPO as the therapy in pregnant patients. And then I'll tell you that there are 2 new TPO agents like eltrombopag, one of which, avatrombopag, was FDA approved 6 days ago in the United States for treating ITP. I'll describe this since I've been working on the development of this drug for now 20 years. And then just for fun, I'll describe 2 things if there's time. I'll describe using light to make your platelets better, which is not ready yet for prime time yet. And I'll describe things that inhibit something you haven't heard about called complement. That's not being polite to you, but it's a way that the body chews up platelets. So the things I'll focus on are inhibitors of the macrophage chewing. I'll talk to you about making the antibody disappear, and then I'll focus on new agents that will boost your platelet production. So the FcRn pathway, what a big and horrible name. So let me make a cartoon version of this. So here's your platelet. Antibodies come along and they bind to the platelet and make it disappear. So a nice therapy for ITP, if you can make it work, is to make the antibody disappear. And so to make a long story short, 40 years ago, you could put people on a machine called a pheresis machine and actually just take the antibody off physically and make it, and that made the platelet count rise. So you could actually take away the antibody, the platelet count would rise, but you can't go on this machine it's like dialysis every day. This isn't doable. So there are ways to make the antibody disappear, and it so happens that we have a really neat thing. This is a cartoon version of an antibody. This binds your platelets, and there's another part of the antibody called the Fc receptor, and this regulates how antibodies are distributed in our bodies. And to make a very long story short, there is a neat device in our bodies which women need for all of us to be alive. It's this red substance called an FcRn receptor. This is something that binds to the antibody here and it stabilizes it. And let me describe how this works. Let's pretend, here's mom here, and let's pretend baby's down here. This is a device that transfers antibody from mother to baby. That was how this was discovered, 50 years ago. So what happens here is that antibody goes here is, we take in our placenta and in our blood vessel cells called endothelial cells, we have these cells chew up plasma. Every day your plasma is being turned over, being gobbled up and then spit out again by your blood vessels. So antibody binds in here, and then the pH goes from 7 down to 3, and the antibody binds to this receptor, and other proteins are here, and they then get destroyed. This receptor prevents the antibody from being destroyed. It recycles and is released. So this gives antibody, which is called IgG, a lifespan in your body of 28 days. It lasts for a long time. So your antiplatelet antibody hangs around for a long time. So if you could paralyze the system here and make it disappear, then antibodies will be chewed up very fast. And if you don't have this receptor called the FcRn receptor, what happens is the antibodies you got disappear very fast. They live for 1 day rather than 28 days. So if you could have a drug that was developed that would actually paralyze the system, this would let you maybe get rid of the antibody. And these are now here. These are the names of them. There are monoclonal antibodies, there are peptides, there's a thing called ABDEG. These are all terms you don't have to think about, but there are drugs that are being developed that will turn off this thing called the FcRn receptor and allow antibody levels to drop. And here's one of them. This is one we've been developing recently. And if I give this is in monkeys. We've done this also in humans. You give three doses of this drug. Within four days, the antibody levels drop from 100% down to 20%. So we can drop your antibody, both good antibody and bad antibody, by 80%. And the hope is this is going to be enough to make your antiplatelet antibody reach a low level and your platelet count will rise. And as I'll show you in a second, we've shown this in about 30 patients in a study that will be published shortly. So let me show you the names of these things, and it's just like doing a cartoon version. They have names like efgartigimod, okay? That's really cool. Or rolanzizumab. These are things you can't, it's like going to a medieval convention, these names. But there are 4 of these in development right now, probably 6 more. And the one that's been furthest along, and we're going to publish it shortly, is the efgartigimod molecule. And what we've done is we've taken 13 patients to get 1 dose of drug, another group to get a lesser dose of drug, and then we have placebo patients. So we got green, blue, and whatever color this is. And they get treated only for 3 weeks. This is a very short study. The effort is to make the antibody levels drop. And to make a long story short, and I just apologize for this, in the gray here, here's the magic number. You want to get above 50,000. All but one of those placebo patients had their platelet counts below this magic number. At the lower dose, many patients went to a higher value, and at the higher dose, almost all patients responded to this and had their platelet count rise. And obviously, When the drug was stopped, the platelet counts then came back down to normal. But this was a nice demonstration. And we talk about response rates here. About 60% of patients responded in 3 weeks by having their platelet counts rise over 50,000 by dropping their antibody titer to a low enough level. So this is a form of therapy. It's now going to be extended to phase 3 studies. The old machine was called a plasmapheresis machine that sucked antibodies out. This will allow us to give patients a drug once every fortnight. That's a subcutaneous injection. You can give it to yourself. It's 0.3 mils that will make the antibody levels drop and make the ITP disappear. And it will happen, it'll respond, some 60% of the time. It may not cure the ITP, but it's a nice thought therapy. It may be also a replacement for IVIG as to rapidly get your antibody levels down and let the platelet count go up. This is one group of therapies. There are 7 studies being projected in ITP, 2 of which are underway as what's called a phase 3 study that are underway right now. Any questions on this? Yeah.
The follow-up, how long would you be looking at these patients for to see if there's a sustained?
Yeah, so these studies just haven't been done yet. I gave you 3-week data, which is obviously trivializing the topic, but this gives us proof of principle. The phase 3 studies will be for 26 weeks, and then we'll have patients that we're going to systematically remove from a drug and see if their platelet counts fall. And to be honest with you, my expectation is that, like other drugs, when you stop the medication, some will remain in remission, and others will fall again, and they get put back on their drug. But this is like IVIG works in a similar fashion. This is like making your antibody just disappear. We hope this is going to work in many patients. But again, it may not be a cure for ITP. Other comments? Yeah.
Just a quick question. So when you address the FcRn receptors, does that promote the destruction of all of the antibodies in your body?
Yeah, so again, you hit the nail on the head. So we drop all different types of antibodies by 80%. The good news is that you don't need that many antibodies to protect you from infection. So to date, the good antibodies you want to keep are decreased by 80%, but not low enough to put you at risk for infection. Other comments? So this is a very interesting area that's going to be, I think you'll hear a lot about it in the next 2 or 3 years. So the next agent is now on the market in the United States. It's called fostamatinib. This is a thing called a SYK, not S-I-C-K, but S-Y-K inhibitor. And let me go back to my cartoon model. This is our platelet again. They're being attacked by antibodies. The antibodies gang up on the platelet here. The platelet is now coated with antibodies saying to the macrophages, eat me. They then bind to this receptor on the macrophage here called Fc gamma R3 receptor. And then they get et. And what happens here is when they get eaten, they go inside here, but it depends upon a molecule here called a SYK kinase that facilitates this internalization process. So you need this thing to be activated to have the platelets being eaten. I won't have time to talk about it, and Rob already mentioned it. The thing called a BTK inhibitor also is necessary for this process. I don't have time to talk about this inhibition, but I will talk about the drug that's now been developed to inhibit this. If you inhibit this, you prevent platelets from being eaten. And how do we know this? Well, one of our buddies called John Semple in his group took mice, and here's a normal mouse platelet count. You can make mice thrombocytopenic. You can then give them IVIG and their platelet count rises, or you can give them sugar, water, and nothing happens. But this drug orally restores the platelet count in mice almost to a normal level. So this is the basic science statement that this drug would work. And then you do a large clinical trial, and our good friend Dr. Bucell did this on 2 different studies. And the way this is how you take patient ITP, and this is one study here. 51 patients get oral medication twice a day, and 25 get placebo. And then you ask yourself, what the heck happens? To make a long story short, and this is not the most exciting story, and I admit that. If you look at patients who have a stable response, platelet counts remain above 50,000. Only 18% of patients responded in the folks who got active drug versus 2%, one patient out of 91 who had the placebo injection. Yeah, it looks okay, but 43% of patients had some kind of response with platelet counts going over 30,000. And as I said, we declare victory over 30,000 to most people. So it's not the most impressive drug for having a bigger rise in platelet count. But modest rises are seen in a lot of patients. And to give you a picture here, this is the patients who got the responses. Here's the placebo group, no response. The responders had platelet counts on average that over time rose to about 100,000. So this drug has now been approved in the United States for therapy. It has a modest response rate. It's probably, and I hate to use the word third-line therapy, but for many patients, this is something we use after a TPO receptor agonist failure. It's FDA approved now for adult patients who have any stage of ITP who have failed initial therapy with corticosteroids, but many of us will probably use it as a third-line therapy. It's not my favorite drug. It's got a few side effects like diarrhea, but in some situations, this has been a God-saving, a platelet-saving drug for many patients. So it's available in the United States. Costs are about 85% of the same price of the TPO agent. So none of these therapies are particularly cheap, as you can imagine. So let me mention an old drug. We developed this in 1994, so it's been a long time. Recombinant TPO is the one that Dr. Bird mentioned and given to cancer patients caused thrombocytopenia rather than just making it better, because antibodies formed against a different version of this. But if you take the pure drug, not a version of it that was made by one of our friends, recombinant TPO has a nice effect. Here's that megakaryocyte being attacked in your bone marrow. Remember, this is the thing that's being attacked by antibody. Antibodies attack, lymphocytes attack. The megakaryocyte tries to die. You then give a TPO agent, like recombinant TPO, and the megakaryocyte lives, and it makes your body make more platelets. So all of the TPO agents, L-trombopeg, avatrombopeg, ramipelstim, and recombinant TPO, make those dying bone marrow cells live, and they make platelets. So this is how these agents work in general. But recombinant thrombopoietin, as I said, was invented back in the 1994 era. There were issues with a version of it, not the one I'm talking about, a different version. People made an immune response to it. But in pregnancy right now, and this is a study published by some of our friends in China, basically, if you're a pregnant lady and you have low platelet count over here, they were given different versions of this drug prior to delivery. They then had a tapering dose after the delivery. And to make a long story short, this drug raised the platelet count from bad levels, 10 to 20,000, to therapeutic levels within a fortnight. And they then had deliveries that were not complicated. 75% of patients responded to this. So recombinant TPO is now used in China. It will probably never receive a label permission in the United States for this because the company making this drug in China never tested for antibody formation. But again, I mention this to you because many of us think that sometimes that the newer, our agents that we have, like ramipelstim, might be used in the same context. But that's a discussion Dr. Gernsheimer will answer in a few minutes. Now, let me turn, any questions on this for any pregnant moms here? Any pregnant dads here? They're oftentimes more worried than the patient, but anyhow. So let me talk to you about another thing that's now here. It wasn't here a week ago when I made these slides, but it's here now. This is a drug called avatrombopeg, previously AKR501, then YM477, and then E5501. It's now got a brand name called Doptelet. What a nonsensical name. This is probably a better and more potent L-trombopeg that you'll hear a lot about in the coming months. And as I said before, this is our megakaryocyte being attacked, and to make a long story short, the avatrombopeg comes along and it binds the megakaryocyte and makes it live. So just like the recombinant TPO, all of these agents make your megakaryocytes live longer and better. So to make a long story short, and I'm going to just focus on 3 bullet points, avatrombopeg equals L-trombopeg, but has no food interactions. It's 4 times more potent than L-trombopeg and has no hepatic toxicity. So we've been studying this now since 1998, and we've now got this drug approved as of last Thursday. So just to make a long story short, if you give avatrombopeg to a healthy volunteer, these are different doses of the drug, nothing, 3 micrograms, 10 and 20. There's a huge rise in platelet count of almost 400,000 if I give it to a healthy person who's got a normal platelet. So your platelet count rises a lot. In contrast, L-trombopeg rises your platelet count in healthy volunteers by about this much. So this is a much more potent drug. If you compare potency of L-trombopeg for 10 days, which is this platelet count rise, here's the rise of avatrombopeg, and we had to stop the dosing because the platelet count's going too high. So this is a much more potent drug in patients, in healthy volunteers. Now, what about ITP? We published a study about 4 years ago, and to make a long story short, if you look at placebo, this is now all ITP patients. You get a sugar water pill versus different dose of avatrombopeg. What's really neat is by day 7, we have a 67 to 93% response rate in ITP patients to this drug. This is comparable to the other agents we use in TPO agents, but that persisted for a long time afterwards. If you look at long-term in the study, we start with a low platelet count, people get put on drug, they remain on it, we stop it, and the counts drop. So this is a 24-week study we published in 2014 on this drug. 6 months ago, a not quite as good but larger phase 3 study was done. Remember, phase 3 study means it's the last phase before a drug gets approved by most regulatory agents for treating a disease. There are 149 patients, a small study where ITP were identified. 32 got avatrombopag orally, 17 got placebo, and to make a very long story very short, response rates, this is a 24-week study. The patients avatrombopag had a platelet count over 50,000, 12 of 24 weeks versus 0.1 week out of 24 with the control group. This is what's called a placebo-controlled study. So this is a huge statistical difference. And finally, if you look at the platelet counts, the control patients are down here. Their platelet counts didn't rise. The avatrombopag patients rose like they always do rather rapidly, but then they settled down and were above 50,000 for the duration of the study. The study was then continued and patients continued on a maintenance dose. And this is the data that has supported this drug to be approved last week by the FDA. So avatrombopag, Doptelet, is indicated, this drug was previously approved for liver disease patients who had low platelet counts, but it's now approved as of June 27th, 2019 to treat ITP patients in North America. I think this is going to change the game for many patients who are having troubles with L-trombopag to make this maybe a more easy and maybe a more efficient pathway. Lastly, in terms of this drug, patients whose counts went up too high had the nice advantage. They then took the drug 3 times a week, 2 times a week, or 1 time a week. So many patients, half of the patients, were taking a pill for their platelet count only twice a week. So you may find that this is going to, over the next couple of years, change the game in terms of oral therapies for ITP. So I want to talk to you about light. Okay, so this is a thing that's on the horizon that hasn't been FDA approved by anybody. It's not been given to patients yet, but it's given a lot of mice and a couple of monkeys. So here's something that Rob was showing you. This is a megakaryocyte in your body, okay? It starts to fragment and it makes little things like this, which are platelets. This is how platelets are made. This is done in a test tube, but this is what this megakaryocyte self-destructing and forming platelets. So this is how we make platelets in our body from these cells called megakaryocytes. It depends upon a huge amount of energy. This is a very energy-consuming process. And here's another example of it, if I can make this work. So this is in a mouse. This is a megakaryocyte in a blood vessel, making these long, what are called proplatelets here, and that's how you're making platelets. So there's another big megakaryocyte putting in the circulation this long strand. It then trifurcates, and these are platelets coming off. So this is what's happening all of us right now. This is how we make platelets in our body. This requires an enormous amount of energy. So where does energy come from in our cells? It comes from a thing in our cells called mitochondria. So mitochondria are the batteries for our bodies. They make energy for a whole bunch of processes, and I think right now what's important is mitochondria are hugely important in how platelets are made from megakaryocytes. So let me describe to you the importance of mitochondria. So you can do an experiment where you take bone marrow from people and get precursors to what are called megakaryocytes, the cells that make platelets. You can then grow them for 24 hours, then grow them for 3 days, and in a test tube, which is this thing here, they make platelets. So what happens is that you can do experiments. And the experiment we did was we took a laser and irradiate this plate for 5 days and asked, well, does this make any difference in megakaryocytes? And to make a long story short, this is a non-irradiated megakaryocyte after 24 hours. It's not doing too much, but this one here, given low-level laser light, is becoming a very big, abundant cell making platelets. And if you measure the platelets in a test tube after 3 days, the control group, not irradiated, doesn't make a lot of platelets. You can double the platelet production by giving low-level laser light. So this is in a test tube. What happens in vivo? If you take a mouse, you give a mouse or a human low-level laser light. It goes right straight. It goes in 8 to 10 centimeters in humans, so it goes right through a mouse. If you do this to a mouse, you can show that a substance called ATP, which is the energy source in mitochondria, You give the laser light, all these different cells in your bone marrow increase their ATP. They're much more energetic. And if you then take the precursor cells and grow them in tissue culture, they grow much more rapidly. So this is demonstration that low-level laser light in a whole mouse sort of charges the batteries of that cell and makes them make more platelets. And so what you can do is you can take a mouse and make them thrombocytopenic by adding antibody. Platelet counts drop. Low-level laser light on days 3, 4, 5, and 6. Within 24 hours, platelets start to rise a lot. So we can take a mouse and make their platelet count recover very fast from ITP. We now have a bigger thing for a chimpanzee, for some rhesus monkeys. We're doing these experiments in rhesus monkeys right now. We're also building the big device for humans. So we're going to test this in humans with a variety of low platelet count productions. And to make a long story short, here's how this whole thing works. You've seen this slide way too many times, but here's a version of it. So this is a megakaryocyte. It's got some batteries in it. And what's happening here is if you make the animal or human have ITP, what happens is that the megakaryocyte starts dying. And this is a process called apoptosis, and there are a whole bunch of things get activated, but they're all activated by the mitochondrial batteries running out of steam. And so you can then shine a light on these guys. You can recharge the batteries. The megakaryocyte now lives, and it makes platelets. And so this is going to be tested in monkey models in the next couple of weeks, and it's going to be tested in humans sometime next couple of years. But we have a whole device being developed in low-level laser lights, like going to a tanning box. So someday, if you have ITP, you might just go into a box and get tanned, and it doesn't tan you, by the way, it's the wrong wavelength. But so this is it. And I think right now, the last thing I'm going to show you, and this is something that is here. This is another clinical study. I'm not going to describe this in much detail. This is a thing called complement, and this is the last cartoon version I'll show you. If you have ITP, you've got your platelets. Antibodies form against the platelets. They then bind here. And I showed you before they get consumed by this direction, but there's another pathway that causes ITP. There is a thing called complement that tags onto these complexes, and it shuttles them to the liver where they're destroyed. And this is called complement activation. It sometimes shuttles these to the liver where they're destroyed. It also can cause them to explode inside of your circulation. Here's a platelet. Antibodies bind to it. This yellow stuff called complement gets activated on it. Complement coats your platelets. Some go to the liver and are destroyed there. Others have more complement activated on it, and they just go pop in your circulation. This is an old topic from the 1980s that has now been re-explored. And to make a long story short, and this is the last comment I'll make, there are inhibitors of complement now available that turn this off completely. You know, the part of a clinical trial that's underway right now. And of the 7 patients given this drug, 6 of the 7 had their platelet counts rise within 6 hours. 6 hours of getting the treatment. So platelet counts were 3,000 at noontime, and by 4 o'clock in the afternoon were 35,000 and normalized within 24 hours. So this may be a pathway to explore enormously that's going to happen in the future. So I think on that I'll stop and leave you my last slide about ITP, which is this right here. What you really need is a blood purifier. This is an old tonic that was available in Nova Scotia many years ago that is still available at the local store near your place in Nova Scotia. I used to have a house. Anyhow, so thanks very much, guys.